You're muted.
Good afternoon from Singapore. Welcome to the 26th ISCP, the fourth session on clinical pharmacotherapy in hypercholesterolemia, targeting the bad, not forgetting the ugly. Okay, these are our faculty today. We have Clinical Associate Professor Jack Tan, Professor Augusto Gallino, Professor Heinz Drexel, and Datin Dr. Ong Mei Ling. And I'm Jin Shing, a pharmacist from National Heart Centre, Singapore. The content of this webinar is copyrighted by the ISCP and should not be distributed without the prior permissions of the ISCP. The view and opinions expressed in the webinar are those of the faculty members and do not necessarily represent those of the ISCP. The session will be live streamed via Wandle, ISCP and APSC Facebook and YouTube pages. The European Board for Accreditation in Cardiology grants CME points for attendees who attend the full session. You will receive your certificate of attendance upon completing a survey sent via email after the webinar. Please use a live Q&A box if you have any question. We will try to answer all your questions if time permits. If not, we will answer via email. It is my pleasure now to introduce our first speaker, Professor Augusto Gallino, the past president of ISCP. Professor is practicing in University of Zurich, Switzerland. He will be presenting on precision medicine for a cost-benefit use of PCSK9 inhibitor in primary and secondary prevention. Professor Augusto, please.
Dear Chairperson, ladies and gentlemen, here the title of my talk. You see on this slide the milestones in cardiology, the role of statistical probability, and the big mega trials. In fact, you see here the death per 100,000 inhabitants, and you see in 50, 70 years the downhill, and the major discovery was probably risk factors among other achievements in cardiology. And in fact, the introduction of statins was enormously important. But we probably have to move from randomized controlled trials to personalized precision medicine. And I cannot resist to cite my teacher, Attilio Masari, who got actually in the last 100 a visionary view. In fact, he actually argued that RCT are not explaining all the picture. If you look at this data where a subject with risk factors are depicted, you may notice that we got indeed through a treatment in the subject with 30% risk, you got down to 15%, so a 50% reduction. But Masari alluded why the large majority, in spite of, with the same risk, in spite of the same global predisposing factors, doesn't develop event. And the other way around, why a substantial percent develops events in spite of correction of risk or in the absence even of any known risk factor. Well, we know that in 2015, President Obama launched the new precision medicine initiative to bring us closer to curing diseases. And actually the whole picture changes with the full discovery of the Human Genome Project achievement. We went to a revolution and many expectations. Precision medicine was defined in 2003 to the use of information about a person's genetic makeup to tailor strategy for the detection, treatment, or prevention of disease. Now, the CDC and actually the National Institute of Health and Clinical Excellence defined that familial heterozygote hypercholesterolemia and precisely the cascade genetic testing is a tier 1 condition for precision medicine. So we see that in this rare disease, which is not actually so rare because as you see on this picture, it is the quite most prevalent genetic-driven cardiovascular disease at all. And if you are looking at the detection rate of this disease, which is prevalent out of 200 individuals, we see that my own country is pretty poor with a 13% detection rate if compared to Netherlands, which nowadays is up to 90% detection rate. So we launched 1 year ago a Swiss prospective, multi-center prospective trials on cascade genetic testing in familial hypercholesterolemia, and we are testing now, and we have tested about 100 families at 3 levels. And this is the picture is in the whole country as a project was now running. And the major aim is to improve detection from 70% detection rate up to 15% in 2-3 years in order to actually go for earlier and long drug treatment. So a sort of a really precision medicine project. And the all is based on the large body of evidence. In this famous slide, you may appreciate if you're just looking at the blue meta-analysis line of the Mendelian randomization studies, where if subjects are randomized to a protective gene versus subject who are not protected, you got, as you may appreciate, a 50% reduction in cardiovascular events. So we are moving slowly but sure from a cumulative exposure model, where we know that not only the quantitative reduction of LDL, but in a sort of a similitude to the PEC years model, to a LDL years model. And in fact, at the bottom of this slide, you see what we will want to actually prevent, like in heterozygote familial hypercholesterolemia, actually to start very early while identifying the right patients to treat it. And we can achieve this with 365 pills a year. But nowadays we are going to use probably in the near future monoclonal antibodies, giving just 26 treatment a year, and even better if we are going to silencing interference RNA, inclisiran, and this is music for the future, vaccination or gene editing. But what you see, if you are going in this direction, reducing the treatment interval, we will probably get a much more better adherence. And here the data from the study, one of the Augusto studies, actually in heterozygote familial hypercholesterolemia, where you see a stable, steady, during the time elapsing reduction of LDL, even giving the drug every 6 months. Now, I'm not an expert in cost-benefit analysis, but I went through at least 20 papers and meta-analysis, and there is no doubt, if you look at the quality, that the effectiveness of PCSK9 inhibitors is well documented, but all agrees that high cost remain prohibitive. And maybe the way to go around this problem is to come back to precision medicine, as Kay Ray actually alluded. And if you may appreciate in this picture, he actually shows within the diagram the number needed to treat. And if you are going and sort out the patients, like in the x-axis, with very, very high risk, over 40%, and very high LDL, you've got a number needed to treat of 9, whereas if you are going for the lower risk, you will have a very higher number and much higher cost. So high cost yield a slow uptake of this blockbuster drugs like PCSK9 inhibitors. And in fact, we have several problems: the access, the system cost stressed, global cost in a country is very important. You have to take it into account. And it will be very important that all the stakeholders, including cardiovascular specialists, and I would say cardiovascular pharmacotherapy is very important under this aspect. So I can add up with the following sentences. The list prices of PCSK9 inhibitors are at nowadays 50% higher than generic statins, and only a small fraction of their higher cost is likely to be recovered by prevention of cardiovascular event. Second, their value will be improved by substantial price reduction, and the budgetary impact of PCSK9 inhibitors will be very large if all potential eligible patients were treated, which poses dilemmas for policymakers, payers, and society. I thank you for your attention.
Thank you, Professor Augusto, for the insightful lecture. Now I'm going to introduce our second speaker, Professor Heinz Drexel. Professor is practicing at Vorarlberg Institute for Vascular Investigation and Treatment, Austria. He will be updating us on emerging drugs for the treatment of hypercholesterolemia. Professor, please.
Welcome, ladies and gentlemen, to this talk about emerging drugs for the treatment of hypercholesterolemia. This year is a fascinating year for new hypolipidemic drugs, and it is two drugs that we want to focus on in the next 10 minutes. Here you see my curriculum, and here my disclosures. Now, you need to know your enemy if you want to attack a disease, and our enemy is, if you look at lipoproteins, the LDL particle, because this is the main cholesterol carrier in our blood. There are others, as you see in this graph, but the most important one is LDL. Why? Because we know in the arterial wall, as you see here, we have the LDL coming from the blood. This particle penetrates into the intima, and we find in the intima all the components of LDL. So this was an early detection that LDL must be very important for the development of atherosclerosis. Please note that it's only the intima where we find the LDL, and it is not across all the layers of the artery. Now, what we now know is that Ldlc is causal and cumulative for atherosclerosis. And just to show the levels of evidence we have and the arguments of evidence is we have epidemiology, we have the pathophysiology, which we alluded to in the last slide, and the histology, and we have animal studies, and now very new in this century, it's the Mendelian randomization approach. You could say the randomized trials nature makes, and the reversibility by therapy. All these prerequisites have been met. Now, if you lower LDL cholesterol by new drugs, it is good to remember a four-step way to success, which we have learned, for example, from statins. The way is first to reduce intracellular cholesterol synthesis. Next is to increase the LDL receptor at the cell surface, the number of these receptors. Third, then, is by these receptors we have an increased LDL clearance from the blood, which of course means 0.4, we reduce the plasma LDL cholesterol. Now, the pharmacological approach for lowering LDLC and emerging drugs in 2021. We have oral drugs on the left and subcutaneous one on the right. Among the orals, bempedoic acid adds to statins and ezetimibe, and among the subcutaneous ones, you know the PCSK9 humanized antibodies, but now we have also inclisiran, and the future will show us more drugs. Now, before we go into the mode of action of these new substances, we should compare their efficacy with the older drugs. If you look at this table, we have the moderate intensity statins, which reduce our blood LDL cholesterol by about 30%. High intensity statins were then developed to reduce LDL cholesterol more pronouncedly by about 50%. Ezetimibe is a bit less efficacious. It is minus 20%. PCSK9 antibodies are very effective, about 60% lowering of LDL cholesterol, and so are the PCSK9 small interfering RNAs, about 60%. However, bempedoic acid, the new oral drug, is in its efficacy about comparable to ezetimibe with 20%. Knowing that, we go now to the modes of action, and here we have bempedoic acid. This is a liver-specific inhibitor of the ATP citrate lyase, which is located upstream of, for example, the HMG coactase reductase. So here we have the statins, and here we have the bempedoic acid that works. And it is important that you are upstream in this biosynthesis of cholesterol, that you have not an accumulation of precursors here. Now, the liver and the skeletal muscle are different in respect to bempedoic acid, because this drug is a prodrug and it comes into the skeletal muscle, but it does not undergo activation. So we have no active drug in the skeletal muscle, and therefore you can expect that there is no active drug in the muscle, which means there is no activity and no side effects in the muscle. So some aspects of this new drug are moderate lowering of LDL cholesterol, good safety. I had not the time to show that, but the data are quite clear. There is, for example, no deterioration of glycemia, no new incidence of diabetes. There are, what we know from the mode of action, no muscular side effects. And an additional perhaps good effect of this drug is it lowers CRP. Now, if we go to inclisiran, this is a small interfering RNA drug, and it comes into the cell. It's an RNA molecule. It goes into vesicles, and at the end, it goes to the endosome, and then this inclisiran is slowly released from the endosome and enters the cytoplasm. In the next slide, we now see in the cytoplasm, this molecule goes to this RNA-induced silencing complex, and by that, at the end, it produces mRNA that is a wrong mRNA, and that leads to deletion of the protein production pathway. So inclisiran directs this RISC complex to cleave target mRNA, preventing protein production. Now, the great advantage of inclisiran versus statins and ezetimibe is that we need only 2 injections per year, as compared to, if you look at that picture, 365 tablets a year. So it is 2 injections per year as compared to 365 pills per year, which is very good for the compliance of our patients. Now, you will ask now, on the basis of statins and ezetimibe, who will benefit most from bempedoic acid? This is my first conclusion. It's first, it is patients not at target with the statin-ezetimibe combination, and this has been shown very nicely for atherosclerotic cardiovascular disease and heterozygous familial hypercholesterolemia patients. Next, patients reluctant or intolerant to take statins can have this drug, and if they have a reason for not taking statin because of muscular pain, then this is a drug of choice, of course. And then pre-diabetic obese patients, those who are prone to become diabetic, when they get statins, they will also not become diabetic if they take bempedoic acid, although we lower LDL cholesterol. And next, now, if we look at inclisiran, who will benefit from these new drugs, and it is now inclisiran, patients not at target, the same as we said before, patients reluctant or intolerant, pre-diabetic patients, and patients not willing to take oral medication, of course, will also take these injections. And we know very well from our patients that we have some that like to have this benefit. At the end, I just want to show you that we have infraphysiological target values now. We could say we go lower with the LDL cholesterol than is physiological in our areas, even also in Asia, but there is no J-curve. In comparison to if we treat hypertension, we go into hypotension, or if we treat hyperglycemia and if we go to hypoglycemia, there is danger. So in summary, we could say we have the takeaways. Ldlc is causal and cumulative for atherosclerosis. The new oral compound bempedoic acid lowers LDLC by 20%. The new subcutaneous compound is very efficacious with -60%, and outcome studies of these two drugs are underway. This is important not to forget that at the moment we have very good studies but not outcome studies. And with that, I thank you for your attention. Thank you very much.
Thank you, Professor Heinz, for the wonderful updates on the two new classes of drugs, bempedoic acid and inclisiran in LDL drug reduction. Now, let us switch our gear from LDL to the ugly triglyceride. Our last speaker, Datin Dr. Ong Mei Ling, she's a consultant cardiologist from Clinical Hospital, Penang, Malaysia. She will be presenting on focusing on the ugly TG beyond the bad LDL, story with a fishy ending. Dr. Ong, please.
Hello, I will be speaking on triglycerides, beyond LDLC, and I'll spend a bit of time on omega-3 fatty acids. These are my disclosures. First, the epidemiology. The prevalence of high triglyceride is in the region of 10% in the adult population. In addition to elevated LDLC levels, both elevated levels of triglycerides and low levels of HDLC are independent predictors of the risk of coronary heart disease. This is data from a meta-analysis, the Emerging Risk Factors Collaboration, which may be familiar to many of you. This correlates the various lipid parameters to coronary heart disease. You can see on the right panel a positive correlation between coronary heart disease and non-HDL cholesterol, a strong negative correlation with HDL cholesterol. The story is a bit more complex with triglycerides. There is a positive correlation after correction for age and sex alone. However, when we adjust for several other risk factors, including HDL and non-HDL cholesterols, this association is very much weaker. A more recent study by Dr. Valentin Fuster's group showed that outside of the coronary arteries, they studied vascular territories, including the carotids, the aorta, the ilex, and the femorals. In these 7 vascular beds, it was found that with increasing triglyceride levels, there was an increase in the presence of subclinical atherosclerosis in these 7 vascular beds. Additionally, it was found that the number of vascular territories, as marked by these bars, are increase as you increase the triglyceride levels. Finally, among patients treated with high-intensity statins, a residual risk persists, particularly in high-risk subjects. This residual risk is due to many factors, but for purposes of this lecture, we will be talking about the residual triglyceride risk. We know from the Proof-It-TIMI-22 trial that even with normal levels of Ldlc, patients who achieve a lower triglyceride level did much better in terms of CV events. More recently, Dr. Fuster's group also documented that compared to patients with high Ldlc, patients with normal LDL cholesterols also had a protective effect if the triglyceride levels were low. There are many causes of hypertriglyceridemia, but in our clinical practice, the more common ones are obesity and diabetes. Of course, we should be attentive to drugs that may be associated with raised triglycerides. Less than 5% of patients can have a genetic cause for their very high triglycerides. Here is a treatment algorithm suggested for patients with elevated fasting triglycerides. First, define and achieve the Ldlc goals. Next, we should define the non-HDLC goal, treat secondary causes of hypertriglyceridemia, and implement lifestyle changes. What are these lifestyle changes? Alcohol abstinence, weight loss, aerobic exercise, and dietary changes. If we are not successful despite these measures in controlling HDLC or triglycerides, then we go on to medical therapy. This includes CV risk reduction and therapy for acute pancreatitis. I will not be covering acute pancreatitis in this lecture. As for CV risk reduction, first-line therapy is statins. Then we go on to the triglyceride-lowering drugs. Here are some triglyceride-lowering drugs in decreasing order of potency: fibrates, omega-3 fatty acids, niacin, and statin. However, randomized controlled trials of triglyceride-lowering therapies have generally not shown benefits on ASCVD. Here are some randomized CV outcome studies with triglyceride-lowering drugs. First, the fibrates. They showed initial promise. In the absence of statin therapy, there appeared to be some CV benefit. However, in the ECHORD study, where statins were used, fenofibrate did not give any CV protection. The next group, niacin, was unsuccessful in preventing CV outcomes with or without statin therapy. The omega-3 fatty acids are a bit more promising, and of the emerging treatments for hypertriglyceridemia, omega-3, particularly EPA in the form of icosapent-ethyl, seems to be the most promising, as evidenced in the REDUCE-IT study, which I shall explain in a moment. First, let me remind ourselves that there are three types of omega-3: DHA, EPA, and ALA. DHA and EPA have different effects on the cellular membrane. EPA stabilizes the cellular membrane, resulting in less cholesterol oxidation and inhibiting inflammation. On the other hand, DHA destabilizes the cellular membrane and reduces the antioxidant activity. The REDUCE-IT study recruited patients, high-risk patients for primary prevention or secondary prevention patients, and these patients had modestly elevated LDL levels and treated to normal LDLC levels. They were randomized to receive icosapent ethyl 4 grams a day or mineral oil placebo. And this was a very significant finding, a 25% reduction in the primary endpoint as shown. The conclusion was that compared to placebo, icosapent 4 grams a day could cause a reduction of 20% of death, 31% heart attacks, and 28% of strokes, with a very low rate of side effects. But are the reduced benefits due to lipids alone? The lipid lowering was modest, as you can see here. And if we plot the lipid lowering onto this cholesterol treatment tri-list meta-analysis, you will find that the benefit from reducing far exceeds what you would predict from lipid lowering alone. Perhaps the results are not all due to triglycerides. It is suggested that only 1/3 of the benefit was due to lipid lowering. 1/3 could be due to the anti-thrombotic effects, and the rest of the benefit could be due to BP lowering, anti-arrhythmic effects, and anti-inflammatory effects. Next, we have the strength study. This study also studied high-risk individuals and randomized them to receive omega-3, a combination of EPA and DHA, versus a corn oil placebo. And the results were disappointing. There was no difference in MACE at the end of the study period. So why the difference between REDUCE-IT and strength? Both had comparable triglyceride lowering effects, yet they had different results on CV outcomes. Suggested mechanisms: were there triglyceride independent effects of EPA? Did the increase of DHA in the strength study offset the benefits of EPA? Could the choice of placebo, mineral oil, versus corn oil have impacted the efficacy of the statin? Dr. Fuster's group suggested that the different properties of the omega-3 fatty acids, EPA stabilizing the cell membranes and DHA destabilizing them, could play a part in the differences in these two trials. The effect of resolvins, mediators derived from omega-3 fatty acids, actively facilitate resolution of acute inflammation. And we know that resolvins generated from EPA and DHA are different. Perhaps if we control these lipid mediators, we could provide treatment that would reduce inflammation and treat atherosclerosis. In summary, my key take-home points: epidemiologic studies established triglyceride as an important contributor to ASCVD. Ldlc is the primary treatment target for lipid-lowering therapy. The first step in the treatment of high triglycerides is the implementation of lifestyle interventions. Next, we go to lipid lowering, LDL lowering using statins to reduce vascular risk, and this is independent of the statin effect of triglyceride lowering. Previous trials with fibrates and niacin did not provide conclusive evidence of ASCVD reduction, particularly in patients who already had optimal cholesterol levels. And emerging treatments, example omega-3, high-dose icosapent ethyl, may benefit some patients. Thank you.
Thank you,
Thanks.
Dr. Ong.
Thanks,
Okay,
thanks everyone. That was a great 3 talks. There are a few questions and we have a few minutes to address those questions. I'd like to put some of the questions together to ask Augusto as well as Dr. Ong here. Grouping together the question, there's a question about LDL and the very dense LDL, as well as the levels. do you think the agents counts versus, it doesn't matter how you get to the level, or is there a difference between using a statin, for example, versus ezetimibe versus inclisiran, PCSK9 to get to that level? And whether you need, is there any of these drugs that target the denser LDL more than the others? Augusto, please.
Yes, there is some slight differences as Professor Drexel alluded. Maybe he will be the best person to answer this question. Anyway, no matter the way you're going, at the very end is the level you would achieve, and the way presented from the ESC guidelines in terms of the expected percent in lowering will guide your treatment if you have a patient in front of you. But Heinz may better answer this question.
Unfortunately, Heinz didn't dial in, so we'll get Mei-Ling. Maybe,
Okay.
What do you think, Mei-Ling?
I think it's just the level. As low as it will go, whether you do gastric bypass surgery, whatever you use, I think it is just get it as low as possible.
Okay, so you don't believe that there's any particular advantage of query anti-inflammatory drug versus just targeting LDL levels? Do you need to then differentiate between the drugs, which type of LDL particles they target, or just a total LDL level? Mei-Ling?
Jack, I'm a clinician, not a scientist. So I just look at the LDL levels, and the lower it can go, the better. Obviously, I wouldn't use, what people used to use in the past, thyroxine or something horrible to lower LDL, but any of the current agents we know can lower LDL effectively and safely, then I would be quite happy just with that level. I won't be able to target all these particles because I don't have access to a laboratory that can assay all this for me.
So maybe we go to some clinical questions next, starting with Mei-Ling. There's a question from Josephine about what do you think is the target LDL levels for elderly patients with hypertension, and just combining a question of combination therapy. When do you actually clinically use combination therapies? Meaning, would you combine the new agents with statins or ezetimibe, or how do you clinically use them and the levels?
I guess yeah, just go ahead.
Please carry on.
Okay. No, I mean, I wanted to allude to your wonderful talk. I mean, I guess one of the most important thing is to tackle also triglyceride, which is a pretty frequent mixed dyslipidemia. Then for sure, we didn't pay enough attention for a while to the triglyceride problem. But Dr. Ong may add something on this item.
Dr. Ong?
I'm a statin warrior. I will go for the maximum tolerated statin before I would think about adding. Part of the reason is cost, of course. But statins, ezetimibe, they're cheap, they're safe, they're effective. So I wouldn't start combination therapy. On the first instance, I will go for a maximum tolerated dose of statin.
So statin all the way until it doesn't work or side effects. Maybe Mei-Ling, you can take this question from Alvin as well, who asked about the cost issue. So if you look at the efficacy of combination statin ezetimibe, pretty close to PCSK9. So when in your clinical practice is a use case of PCSK9 inhibitors at the moment?
I think less than 10% of my patients are on PCSK9. This is for secondary prevention. And I think I would follow the algorithms suggested by ACC, our own local guidelines, and I would go for maximum tolerated statin, then I'll add on ezetimibe. And if I don't achieve the targets for the particular risk group that I'm treating, then I would use a PCSK9. I think at that time, the patient also has realized how hard we are both trying, and they are a little bit more compliant and prepared to dish out the dollars, because in Malaysia, most of these patients on PCSK9 inhibitors are self-paying.
So Augusto, in Switzerland, is that the use case of PCSK9?
Yes, it's absolutely correct what Professor Hong alluded. Actually, the first thing is to identify the risk, and I will go in that sense to the highest risk, and I will decide my strategy according to that, first of all, and then I will pursue, as Professor Hong mentioned before, starting with the highest dose statins, then add ezetimibe, and there will be a percent of patients, the majority probably because of now the very high costs of PCSK9. I can imagine that inhibitors will increase if the cost, if the price will go down. We will go preferably in this new direction. But this is music of the future, at least in my own country.
The future looks exciting. The future looks pretty exciting with inclisiran and probably vaccination and genetic therapy, I think. Maybe Mei Ling can take this question from Daniel again. In Reduce It, the use of EPA increases the risk of AF, but there was some sudden death risk protection. So can you explain possibly the effect? You think there's a risk there?
I don't think I know the reason why there is an increase in AF. You know, omega-3 fatty acids have been touted, especially in the early studies, to reduce sudden cardiac death. And it still has some signal that it does. But in the Reduce It and as well as the Strength study, both of them showed an increase in AF. I am not sure. I don't know. Maybe you have some thoughts, Jack?
No, I don't know. I will defer to Augusto as well. Do you have any thoughts?
No, unfortunately not. No.
Jin Shing, any explanation? No, unknown, right?
Yeah.
But I think there is still overall beneficial evidence for EPA use in our subgroup. I just come back to Augusto's wonderful lecture. I thought it was excellent and concise. Can I just pick your brains now? When we say precision medicine, you're talking predominantly about genetic type of prediction. And when do you think we should effect this prediction? Are we ready to do it when they are in their teenage years? And there's also another big branch of precision medicine saying we're using AI, wearables, and other information to effect precision medicine. Where do you see us going? Is it going to be a combination? Is it a GRS, a GWAS type of prediction? Is it only currently for monogenetic conditions? Are we ready for lipidemia manipulation based on this?
Well, it's a moving target. I mean, it will probably go into this direction. Actually, what we are trying with our study is actually to not identify people with the monogenetic variant of heterozygote hypercholesterolemia, but go and try to detect in patients who are negative but have still a very high LDL cholesterol above 6 millimole per liter. Try to identify new genes, and I am sure that I mean, you get obviously a large part of the population will have a multigenetic and not a monogenetic presentation. And I'm sure that within 5 to 10 years, we'll be probably able to scrutinize the population and go to this direction, precision medicine, which is a very broad field, including the possibility not only in terms of genetics, but you know, all the omics will probably be very relevant in the near future.
Thanks, Augusto. Can I ask Mei Ling then, when inclisiran comes in or bemboic acid comes in, maybe you can tell us what your thoughts are about how to apply these two new agents into your clinical practice?
I would still follow, you know, traditional algorithms. Better the devil you know. So I would still reach out for PCSK9. I mean, once I've exhausted the pathway and I'm down to high-risk patient, no target, I personally will think of PCSK9 first. Of course, those patients who cannot tolerate statins, then we can think about bempedoic acid because it's more acceptable, being a non-injectable. Between inclisiran and the PCSK9 inhibitors, I think I can be sold to the highest bidder or the lowest bidder. So it's cost. If the Novartis people can bring it down to 6 months cost of one injection being equivalent to or cheaper than 6 months of PCSK9, I will move over. I think cost is driving a lot of private patient care at the moment because the burden is very great. Yeah.
Thanks again, Mei-Ling, on the side of caution. And just to note that the outcome trials for the rest of the agents are very strong. We still don't have the same outcome evidence for the new agents. Jin Shing, you would like to summarize or finally?
Okay, thank you, Prof. Augusto and Dr. Ong for the insightful and good discussion. So we have finalized the sessions, and then we know that the new drugs is still the question marks on the really good outcomes, and we will try to look for a better future trials that comes in. And for now, actually, I would like to ask you all the last questions that pharmacists always have an issue when the patient asks us, which fish oil should we use? What brand in the markets that should we use? So are we going to stick to the clinical trials with isocol, pentyl, ethyl, or should we use any of the EPAs and in the market if the patients have a moderate hypertriglyceridemia? Dr. Ong and Professor Augusto?
If I can take this, I think eating fish is a good thing. So all of us should eat fish. You shouldn't have your beef steak and then swallow your fish oil capsules. So that's what I tell my patients first. Eat fish. I live in Malaysia. We have a big coastline, so it's quite easy to eat fish. Okay, now, if I used to think that omega-3, we know EPA is better than DHA, but let's just ignore the DHA, just swallow the pill for the EPA that's in there. And it's very hard to get pure EPA. In Malaysia, we don't have Mexipa, this icosapent ethyl. I'm not sure whether you have it in Singapore. But looking at the strength study and several other smaller studies, it looks like, you know, the DHA is not just the innocent, also came into the capsule. The EPA is effective in stabilizing the cell membrane, but having DHA there may actually negate the effect. So unless you can find something with pure EPA, I think it's better not to take. That's my feeling. And as I was reading up for this lecture, I'm feeling more and more strongly against just any fish oil. So I tell them to take fish. If you can find pure EPA, which I cannot get in Malaysia, I would tell them not to take.
Augusto?
That's my answer. What about?
Yeah, Professor Augusto, what is your point of view on whether we should introduce the fish oil for our patients?
Yeah, I usually do the same way, even if we don't get so much fish. We are not so fortunate like in Malaysia, but I try to advise patients who have elevated triglyceride, yes, to go for supplements which may be obtained over the counter, and because of the fact that the way of the habit of eating do not include in our mountains here so much natural yes omega-3. And so I advise at least in the patient number 1 to reduce alcohol intake, obviously. And if they're not coming down, I try to advise a supplement in the way you presented so brilliantly today.
So it's a settings of fibrates.
Yeah, thanks, Augusto.
Thanks.
So I would say that you probably can't eat enough of the oily fish to get the same quantum of the EPA dose, no matter how much you eat. So I would say that if you really want to give it, you probably have to use the trial proven formulations and doses, not anyhow formulations out there. With that, I'd like to thank everyone for their time, participation, and their wonderful talks today. So thank you very much for your wonderful contribution and session. Bye.
Thank you.
Thank you.
Bye.
Thank you, Jack. Thank you, Jin Shing. Bye-bye. Bye-bye.